Well, welcome everyone. We're excited to have you all for our September Journal Club with AOCPMR. We're glad to have Dr. Leavitt with us tonight. We're grateful that he was able to carve some time out of his busy schedule to teach us and talk about this article. Just a little bit about Dr. Leavitt. He graduated from Rocky Vista University, College of Osteopathic Medicine in Parker, Colorado, and he's a current PGY3 at the University of Kansas. We're excited to have him. He's a great guy and very knowledgeable. And so without further ado, I'm going to turn it over to Dr. Leavitt.
Awesome. Good deal. Thanks, Sam. Appreciate you guys having me. Excited to kind of chit chat tonight about an article I picked. Just first things first, it's super informal. So if any questions come up about anything, there's no dumb questions. So anything that comes up that you're not quite sure about or any comments, just feel free to let me know, or feel free to chime in the chat, or throw your speaker on or camera on or whatever and stop me. So without further ado, though, we'll jump into it. So kind of some brief objectives for the night. So our article tonight is by Katharina Oswald and colleagues about lumbar radiofrequency ablation and then some of the sequelae that can happen. But before I jump into the paper, I just want to kind of give you guys a brief overview of lumbar facet joint mediated back pain, as well as the procedure, lumbar medial branch radiofrequency ablation. Some of you may have seen this on your rotations with pain providers or other PM&R doctors who take care of a lot of patients with low back pain, which is a lot of the outpatient setting. So you may have encountered this before. And then we'll kind of delve a little bit into the article using a framework that I recently learned about. Thought we'd give it a try and kind of expose you guys to it and see if it's something you like as far as a framework of analyzing an article. It's called the PP Icons framework. And then the last little part, I just want to kind of talk a little about future research on lumbar radiofrequency ablation with regards to multifidus atrophy and or dysfunction. So we'll jump into it with those objectives in mind. So hopefully we can hit those by the end. All right, so the first topic, so lumbar facet mediated back pain. So as we all know, especially being in a DO school, you learn a lot about back pain. Chronic low back pain, though, as we know, is a very prevalent condition. It's actually the leading cause of disability worldwide. So it's something you'll see regardless of your practice. Even if you go into some other specialty, you'll see a lot of it, but especially in PM&R, we deal with it all the time, not only as an outpatient setting, like if you go into spine or pain or those types of fields, but you'll see it even if you do inpatient. So it's just something to know really well. There's multiple pain generators, though, in the lumbar spine. Among those include internal disc disruption, the ligaments of the spine, the muscles, the paraspinal muscles, with one of those being the multifidus is one we'll talk a lot about tonight, but there's obviously other paraspinal muscles. The spinal nerves, which exit from the spinal cord out into the periphery. Then we have the spinal cord, spinal nerves, I put that twice, and then spinal cord, and then the vertebral bodies, as well as those end plates. And then we have different joints that make up the spine. As we know, the sacroiliac joints down more inferiorly, and then the zygapophyseal or the facet joints throughout the spine. Then kind of honing in on just kind of lumbar facet mediated back pain. So the pain that comes just from those lumbar facets, the prevalence is thought to be as high as up to like 45% of those with chronic low back pain. So pretty big significant factor of a chunk of those patients experience this type of low back pain. Kind of the typical management, we always like to start pretty conservative. So the first part of managing facet-mediated low back pain would be to kind of start with targeted physical therapy. You can try topical agents like diclofenac or Voltaren gel, also known as that, or lidocaine patches or different things, or oral anti-inflammatories like NSAIDs such as celecoxib, or those types of medications are often prescribed. If you can't quite get where you want to be with those kind of non-interventional treatments, there's some other procedures such as facet joint injections, which are one procedure option, medial branch blocks, where you kind of block or anesthetize the nerves which supply the sensation from those joints. And then lumbar radiofrequency ablation could be considered. And we'll talk a little bit more about that. So kind of I like pictures. I think it's really helpful to kind of put things into perspective and kind of give some good visuals. But as we obviously have kind of the body of the vertebrae, the intervertebral discs, and then the zygapophyseal joints are kind of those small joints at the back. They are a synovial joint, like other joints, just like the knee or something. They do have a joint capsule, they have a joint cavity, and they have synovial fluid. It's pretty small. I think it holds like, you can do injections, it holds like half a cc, so pretty small space, but nonetheless, it does have synovial fluid as a synovial joint. So kind of remember the facet joints are kind of synonymous with zygapophyseal joints. So you can I'll probably use those interchangeably. I might probably use facet more, but if I'm saying them, they're the same thing. So talking a little bit about, so we talked about the lumbar facet mediated back pain, kind of honing in on that is the lumbar medial branch nerves. So the sensation from those facet joints is transmitted via these lumbar medial branch nerves. These nerves are branches off the primary dorsal rami, the spinal nerve. So you have the spinal nerve coming out the vertebral canal or the column, and then it breaks off into the dorsal rami, the ventral rami, and then coming off the dorsal rami, you have these medial branch nerves. I'll have a picture here in just a second, so you'll be able to see that. They're branches off that dorsal rami, and they go out and supply the facet joint. So it's really important to kind of understand that the facet joints are dually innervated by two different medial branch nerves. So the medial branch nerve at the level of that joint, as well as the level above. So for example, if you're looking at the L4-5 facet joint, they'll be innervated by the medial branch nerve at L4, but also the one above it, so at L3 as well. So both those kind of come out and provide sensory information and sensation from that joint. Then in addition to innervating the facet joints, these lumbar medial branch nerves also innervate the inner spinous ligament, so between those spinous processes, as well as the supraspinous process or supraspinous ligaments, which are kind of a little bit more posterior, kind of on the top of those spinous processes, and then also the multifidus muscles. So one of those paraspinal muscles that's really a big primary stabilizer of the lumbar spine. So it's really important muscle. It's also innervated by these nerves. So this is a picture I kind of zoomed in a lot because I didn't care about the other stuff. Kind of want to just hone in so you guys can kind of see. But also kind of have these nerve roots right here. So these are kind of equina, and then they come together and form. Out here we have the DRG, and we have the spinal nerve. So we have the dorsal rami, the spinal nerve that courses dorsally, right, into these multifidus muscles. And then we have the ventral rami, or the anterior primary rami. And you can kind of see coming off that dorsal ramus, we have the medial branch nerve that comes right off and then goes to innervate that facet joint. So it's kind of a good cross section where you can kind of see, kind of visualize where that nerve's at. So you can kind of see it's not great. We'll have some other pictures that kind of show it from a different angle. But you can kind of see it kind of lives in between this transverse process. And if you can imagine, there's a superior articular process right about here that contributes to that facet joint. So that's kind of roughly the location where that medial branch nerve kind of lies, right in that kind of space on the column. So that brings me to the next part. So one of the interventions that we can provide for patients who have lumbar facet mediated low back pain, who have kind of failed those conservative measures, who haven't quite met their treatment goals or their expectations, you can offer them a procedure which is called lumbar medial branch radiofrequency ablation. So this is an extremely common procedure, especially in pain medicine. The physiatrists who specialize obviously in interventional spine or pain will do it. But it's a very common procedure. Like I said, it's the second most commonly performed procedure for chronic pain. It can be performed after 2 medial branch blocks. So basically, we'll go in and do 2 blocks or 2, like using local anesthetic. We'll have 2 blocks on different dates where you'll go in and anesthetize that nerve. And if the patient reports greater than 80% relief with those blocks, then they can proceed to radiofrequency ablation. That's kind of the criteria that insurance and some of the studies have kind of figured out. So most insurance companies require that prior to paying for a radiofrequency ablation. It kind of makes sense, right? You don't want to burn or ablate the nerve unless you know or you think that's the pain generator, right? So it's kind of worth it to just anesthetize it first and see. But basically, it involves a percutaneous placement of these electrodes or these needles that have electrodes at the end over those medial branch nerves. So they live at the junction of the SAP, so the superior articular process, and the transverse process, like I was kind of pointing out. I'll have a picture coming up. But that's where the medial branch nerve lives, and you kind of just put the probe right along that area. And This probe is then heated up to 80 degrees Celsius for about 90 seconds. I have a little typo, but 90 seconds to induce neuronal cellular degeneration as well as destruction of that nerve. So it destroys the nerve. So then the thought is that the sensation won't be recognized, right? We won't be able to feel that sensation coming from those painful joints because they can get arthritic and have all the similar things just like any other big joint in the body, but we can kind of relieve that pain. But the thing is, we don't really know. There's obviously, like we learned just barely, right? The medial branch nerves don't only supply the facet joint, right? They supply other things, right? So they supply sensation from different ligaments, but they also provide innervation to the multifidus muscle. So just something to think about with this procedure. That's what we'll kind of get into with this paper. So here's kind of a picture. You can kind of see, don't forget like your Scotty dog type picture. It's kind of an oblique view of the lumbar spine, but you can kind of see, you have your, like, for instance, at this level, you have that superior articular process right here, and then you have your transverse process. So kind of right at that junction, you can see where they place the probe, and that medial branch nerve is kind of wrapping right here, and then the probe is kind of laid down right kind of in parallel with that nerve. And then when it's turned on and heated up, it kind of creates this on that oval shaped kind of area. It heats up and destroys that nerve. It's not very long too, so you would get all the probes in place and then you'd have them all hooked up and then you turn it on and it would heat up for 90 seconds. You'd have to anesthetize the area beforehand, obviously, because it does cause a little bit of pain in that area. So, but normally it's a pretty well tolerated procedure. Like I said, it's commonly performed and people generally tolerate it pretty well. So that kind of brings me into our topic for tonight. So the journal article I picked to review, I just want to kind of provide a quick overview of just lumbar facet-mediated back pain and kind of set the stage for the article so you kind of can understand a little bit more about what this article is talking about and what they looked at. But the title of the article is "The Radiofrequency Neurotomy Does Not Cause Fatty Degeneration of the Lumbar Paraspinal Musculature in Patients with Chronic Lumbar Pain, a retrospective 3D computer-assisted MRI analysis using iSix software." So the authors were Oswald and et al. And her colleagues. It was accepted just like a year or so ago, June 13th of 2022. Excuse me, and it was published in the Pain Medicine Journal. So kind of just a brief overview of the study, just a few of the study characteristics, basically. So it's a single center study, so it's just performed at one place or one hospital. It was a retrospective cohort, so it wasn't prospective. It was looking kind of in the past at patients who had undergone lumbar radiofrequency ablation. And the location of the study was over in Europe, in Bern, Switzerland. So the framework, you guys may have heard of this, and some other people may have heard of this or introduced you to it in the past, or we may have used it. A couple of the docs that we work with here at KU use it, so I figured we'd give it a try. I haven't used it a ton in the past, but figured it would be a good, worthwhile thing to try. But basically, it's just kind of a framework for evaluating a scientific article. It's called the PP icons method. So it kind of looks through those different things. So problem, also patient / the population, the intervention that's performed in the study, looks at the comparison, the outcome, as well as the number of subjects and statistics. So it kind of looks at a lot of the basic things that go on in a paper and kind of helps you evaluate and understand what things are being investigated. And hopefully some of you were able to kind of pull up the link. I think Sam had it in the email. So if any of you guys have it around or have questions or anything, feel free to chime in. But basically the main problem though that they're kind of looking at is, does the relative paraspinal intramuscular fat volume change after lumbar radiofrequency ablation? So they're kind of looking at the volume of the paraspinal musculature, and they're wondering, well, after radiofrequency ablation, so after we burn these nerves that we know innervate some of the paraspinal muscles, namely the multifidus, does the volume of the muscle change? And basically what happens is if there's atrophy or basically just degradation of the muscle or it becomes denervated, basically it just gets replaced with fat. So that's kind of what they're looking at. They're looking at this muscle volume after the procedure. So that's the problem they're looking at and they're looking into, is kind of their question. And then the population, the patients they're looking at. So all these subjects had chronic low back pain, and all these subjects were treated with radiofrequency ablation from those different levels, anywhere from L2, 3, all the way down to L5, S1, so kind of throughout the lumbar spine. They're treated with RFA due to having symptomatic facet joint arthropathy or low back pain related to the facet joints. You can look at the age of the patients. Average age is kind of around 60 years old, so kind of in that 50 to 60-year-old range. And they reported that roughly 55% of these patients were females. Some of the basic kind of demographics that they reported. So one thing that was kind of interesting is they didn't talk about. So a lot of times there's a lot of different kind of controversy as far as like what qualifications should patients meet before being able to have lumbar radiofrequency ablation. They didn't really mention that all these patients had facet joint blocks or medial branch blocks. So it doesn't talk about that process, or if they each had, they just did one medial branch block before doing the procedure, or if they had two, or like what the criteria was. The criteria they just got at least 50% improvement, or was it 80, like I mentioned. So that's something that the paper didn't really mention. It just said all these patients have facet joint pain, and then they proceeded to lumbar RFA. So that was one thing that wasn't super clear in their patient population. All right, and looking at the interventions, kind of like we already mentioned. So basically what they did is they had all the subjects received an MRI of the lumbar spine at some point before they did the analysis. So before they did RFA, they had an lumbar spine MRI, and then at least 6 months following RFA, they had another MRI of the lumbar spine. So before and after, so it's good that they had a comparison, right? They were able to see, okay, here's what the spine looked like before the procedure, and here's what the spine looked after the procedure. I think it's also critical too that they did at least 6 months, because we know that it's not going to cause denervation or atrophy, or fat's not going to come in and replace muscle tissue in just a few weeks or even just a couple months, right? So it's good that they at least waited 6 months or so to get that repeat imaging after the procedure, because it takes time for those like processes to occur. So I think that's a good thing that they waited a little while after. And then as far as their analysis, so on the MRI, they used a special software. It doesn't explain a ton about it, but basically it's called this iSix software that basically just looked at the relative and the absolute paraspinal muscle and fat volume like when they looked at the MRIs, basically. So they did it before and after using this special software, basically, to see if there was any change in the volume and fat in the muscles. The comparison group, this is where it gets a little bit confusing in the paper, where they like aren't super clear about exactly what they did. It's pretty clear what they did, so and parts of it, and other parts it's a little bit unclear. So hopefully I can kind of unpack it for you guys, or if anyone wants to chime in too, feel free to comment. But basically, so the sides of the lumbar spine that were treated with RFA, they said were compared to the sides that were not treated with RFA for those who underwent unilateral RFA. So that makes sense, right? So if they had L4-5 on the left side, had an RFA on that side, they compared it to the L4-5 on the right, and they tried to compare that. So it makes sense kind of what they did. They kind of looked at the side that was treated and compared it to the side that was not treated. The only problem is that sometimes some of the studies show that the medial branch nerves can actually innervate multiple levels of the multifidus, including the other side, as well as the level above and below. So that could be a little bit confusing or a little bit misleading if they're comparing it, because that could also, if you ablated the nerve on the left side, it could also affect the right side, if that makes sense. So they tried to compare it, but there is kind of some concern that it might not be super accurate, basically. And then the other part of the comparison is for the people that had bilateral radiofrequency ablation. So for instance, they had radiofrequency ablation done at L4-5 on the left and on the right side. Then they said they compared them to treated sides, basically. So they said those treated sides were compared to treated sides. So it's not super clear on if they compared it to other folks in this study, or if that same patient population. It talks about it kind of in the, if anyone has it up, it's basically in the methods portion towards the end. But it just says for evaluation of relative fat volume pre to post RFN, relative fat volumes of all treated sides before RFN were compared to the corresponding relative fat volumes of treated sides after RFN. So it just doesn't, it's not super clear on how they exactly compared it. But they're trying to compare it just to make sure that to see if there was a difference, if RFA did make a difference in what was going on, what they compared. So that's kind of comparison part of the study. And then their outcomes, this is what they report in their kind of results section, as well as some of the tables you can see, like there's a clinical outcomes table in table 2. The big one is kind of table 3 though, where it talks about the different layers, and then it looks at them pre and post RFN. So basically what they report in their methods, they said there was no significant difference in pre and post lumbar radiofrequency ablation multifidus intramuscular fat volume was identified. So they didn't find any difference, is what they're saying, in the muscle, in the volume of the muscle before RFA compared to after. They said that the RFA didn't affect it. And they said in their analysis of the 9 of the 20 patients, so there's 20 patients in the study, and it's an analysis of 9 of those who underwent unilateral radiofrequency ablation. So just one side of the spine was treated with RFA. There's no difference in the multifidus intramuscular fat volume compared to the non-treated side before and after RFA. So they're saying compared to that side that wasn't treated, there wasn't any difference that they found. And it's a little bit unclear. So they mentioned that in writing in their results section, but then if you look at their table, it kind of explains a little bit different. But we'll talk about that in a minute when we come to kind of the limitations, and we can kind of chat a little bit about that. So like I kind of already mentioned, so in the study, there's 20 subjects, so not a super big study. There's a couple other studies looking at multifidus atrophy after radiofrequency ablation, and they're even a little bit smaller. So compared to some of them, it was okay, it was good, but still a pretty small study of just 20 patients. And if you look, they kind of looked at their database, right? We said it was a retrospective study. So basically they started out with their whole database of folks who had radiofrequency ablation due to low back pain. And initially they identified 62 patients. So they really chopped it down pretty quickly all the way down to 20. But basically they said they excluded 31 patients because of the patients had acute lumbar back pain, which I don't know, they didn't really specify what that meant. It's like a kind of acute on chronic flare or something. So they excluded them. It's not super clear. Previous surgery, which that seems fairly reasonable just because we know the anatomy would be altered and stuff. Low quality of imaging studies. I don't know if that would be great. I mean, I think they could probably try to redo the imaging or something, or try to make it work. Or there's no availability of follow-up MRI imaging, so they never had follow-up imaging after. And they said the acute back pain is defined as pain duration less than 3 months. They as I'm reading here, they actually did define that a little bit. So patients that had pain for just less than 3 months, they kind of excluded them. But regardless, that kind of just perks you something to kind of look at and think about. How they had like 60 something patients and they chopped it all the way down to 20. So just kind of makes you wonder, like looking at their inclusion and exclusion criteria, why did they chop out all those patients? And because we would obviously like to have a bigger sample size to look at and help us kind of generalize the results a little bit better. But regardless, say 20 subjects. Statistics, I'm no statistician, as most of you probably know. Like we all went to osteopathic school. We don't do a lot of statistics or tons of research, so I'm definitely not a statistician, but I'll kind of mention a couple of things that they did. So they did an a priori power analysis initially, and that kind of just helps, basically from what I'm reading about it, basically just helps determine what's an adequate sample size for a study to produce clinically, practically, and theoretically meaningful results, right? So before you even do your study, you want to know how many patients do I need to actually produce a good study that will bring out results that will actually mean something. Like you don't want to go through all that work to do a study and not have it produce something that's relevant, right? So they did that study initially, or that analysis initially, so that was good. And they looked at group comparisons, comparing different groups with a paired t-test, and then they obviously set their statistical significance of an alpha value of less than 0.05. So to check that there's statistical significance in the comparisons. So that's kind of all the big things about the study. We kind of went through the whole PP icon. So we went through the different parts, right? We went through the problem, we went through the patients and the population, we went through the intervention. We talked a little bit about the comparison and what they were comparing. We talked a little bit about the outcomes and what the authors reported finding. We also talked about the number of subjects, just barely how there was 20. Then we talked about the statistics that they ran to ensure that they could have a good study or that everything was done okay. That kind of brings me to the last part, was the limitations. It's not part of the PP icons, but I think it's always something to kind of think about just as you're reading papers. I think it's always important to kind of think about limitations, or think about things that, oh, they should have done this, or like you're kind of playing like Monday morning quarterback almost for these researchers. But I think it's a good thing to think about, and it kind of helps you if you ever do get interested in research or interested in doing studies, things to consider and things that you can kind of learn from, and things that you can consider when you're doing your own things. One limitation, one clear one, is just that it's only a single center study. So typically a lot of these studies or big studies would have multiple centers, right, with different patient populations. This is just the population in Switzerland. So it could be completely different if you looked at it somewhere in South America or over here in the States. So just only a single center study. It was retrospective, and they didn't have any control group in the patients who underwent the bilateral radiofrequency ablation. So like I mentioned, it was a little bit unclear how they compared the patients who had bilateral radiofrequency ablation. It's also, there's always limitations with retrospective studies, right? The data is already collected, you already have everything, so now it's up to you to analyze it. You can't kind of like look in the future and see how things happen. So that's always kind of a limitation. I already kind of talked about this when we talked about the number of subjects, but just a pretty small sample size of 20 patients. Then, like we mentioned, there's a lot of patients that got excluded. They started out with roughly 60 and they chopped out almost 2/3. So just something to think about. And then the next part is looking at the stats. So if you actually look in the paper and you delve into their table 3, and you look at the actual like volumes and what they charted before RFN and after RFN. RFN just means radiofrequency neurotomy. It's the same thing as radiofrequency ablation. Those are also synonymous terms, basically. You're getting at semantics in between the two of them. But so they reported in their methods that there was no change, right? But if you actually look at like the relative or the absolute volume, you can see that it actually goes down from pre-RFN to post-RFN. So if you look at the actual in their table, it says that it actually did decrease some of the volume in multifidus. So it's a little bit misleading. I don't understand why they exactly didn't explain that in their paper, but if you look at the stats and you delve into some of the tables, there actually was a change or a decrease in the paraspinal muscle volume before and after radiofrequency ablation. The next kind of part or limitation I want to bring up was that there was no functional assessment performed of the multifidus or of these patients with low back pain. I think it's always kind of important to look at the function as well. In some of the other studies in this topic, they talk about the function of the patients and kind of how they're doing and how that relates to things. Just because there is atrophy or just because there is XYZ structural finding, I think it's important also to look at the function of the muscle and of the spine. So there's some functional assessment, whether it's a certain test that they were to perform to have the patients do. I think that would be another important thing to look at. And then another big one is just the lack of standardized imaging timelines, along with only looking at one point in time, right? So if you look at it when all the patients had their MRI after, let me turn to that page. It kind of talks about when they had it. Let me see if I can find it. But basically the main point is, I can't find it right off the bat. Take me a second to scan the article, but regardless, they were all at kind of different time periods. They weren't all like, 6 months after RFA, they had MRI. Some of them were 6 months, some of them were 9 months, some were a year. It was kind of across the map. So it's hard to kind of compare sometimes. Like we talked about, it takes time for atrophy, it takes time for denervation of the muscles to occur. So if they could somehow standardize that, where all the patients had imaging done at 6 months after RFA, at 9 months after RFA, 1 year after RFA, I think it would kind of add a little bit more relevance to the results and kind of make them a little bit more meaningful. So that's something to consider. Does anyone I'm just kind of scanning through everything with the paper. Does anyone kind of have any comments about what we read, or if anything didn't kind of make sense about the paper, and you want to chime in with any comments? If not, it's totally fine. It's all good.
Yeah, I thought it was interesting how they excluded patients who were having continued back pain, or whether it was a flare up or whatever.
Yeah.
Because that's what I was thinking. I was thinking, okay, if they found in their 20 patients that there wasn't a difference, what about maybe those who had continued pain afterwards. I'm guessing these ones weren't having pain, and so they're kind of the perfect model for them to test out, just to rule out any other complications. So I thought that was really interesting, just how they selected their patients.
Yeah, for sure. Yeah, it's a little unclear how they, yeah, the exact like inclusion criteria and stuff with that part. But yeah, for sure. Yeah, thanks for chiming in. Definitely. Anyone else have any other questions about it or anything, comments, or anything that didn't make sense too? Totally fine if confused about any part of it too.
So with the deep layer of the paraspinal muscles decreasing post RFA, do you think maybe if the sample size was bigger, we would have seen a significant difference there? Or
Yeah, I think it could have. I think yeah, having a bigger sample size, I think could definitely play a role into it because it's hard to make like big conclusions based off the smaller sample size, you know. So I think that could definitely help. I think also the standardization of the timing too. Like it's hard to say like, oh, were these all the patients that had a lot of changes? Was it like a year and a half out after the procedure? You know what I mean? That take a lot of time for those changes to show up. It's kind of hard to know if that makes sense.
right. And like you had mentioned, it would be interesting to see if maybe there is some type of functional difference.
Mm-hmm. Yeah, definitely. There's a paper. There's another one that kind of talks about. They looked at like it's called like ultrasound shear elastography. So it looks at kind of they use basically an ultrasound exam of the muscles, and it kind of looks at how the muscles move and different things. Because there's like we talked about, like if there's more multifidus atrophy or multifidus kind of dysfunction or dysfunction of any of the paraspinal muscles, you could have kind of instability of the spine that can contribute more to pain that could then lead to more issues with the joints and different things. I think it'd be good to kind of have a functional assessment of some kind, whether that's with like ultrasound, kind of like I was just mentioning, or if it's different functional tests, like having the patient get up and go and walk or do stairs or go seated to standing or something like that. I think that would be good and add a little bit more maybe clinical relevance to it too. A good comment. Anyone else? If not, we can jump on to the last little part that I wanted to share with you guys. Sounds good. Well, I just want to kind of, the reason I chose this topic actually, so a couple of my co-residents here at KU, we got together with actually a couple other colleagues from different institutions. And we're actually doing a systematic review on this topic just because we were all kind of interested in it. I mean, it's a procedure we do a lot when we're rotating with our spine physiatrists here at KU and different places, as well as in med school. I rotated with a couple of pain docs who were PM&R trained initially, and they did a lot of radiofrequency ablation. So I'd always kind of heard about it and had seen a lot of it done. So I was always kind of just interested in the procedure. But that's the biggest question is like, and it's done so often, and we don't have a lot of like, there's not a lot of complications, or we don't always know what the down the road kind of sequelae of different procedures. I think it's always good to look at those things. That was kind of the question we had in mind. Like, does lumbar radiofrequency ablation cause multifidus atrophy and or dysfunction? So does ablating those nerves, does it have deleterious sequelae down the road? Basically, does it atrophy? Does it denervate those muscles, leading to atrophy, to dysfunction? Obviously, if that spine's not very stable, or those primary stabilizers are knocked out, then you can have progression of facet arthropathy, right? Those joints aren't moving like they normally would. They're not as stable, can cause instability of the spine and lead to other kind of structural changes. So that was kind of our question. It's the first systematic review on the topic. So we've already done kind of our whole literature search. At this point, we're just kind of writing out the manuscript and are getting ready to submit it. So we're towards the end of it, but at this point, and then before when we first started, there's no other systematic review on the topic. It did take a little bit of time. As you can see, it had over like 1,500 studies that we pulled initially that were all related to this topic. A lot of them obviously didn't meet our criteria because we only ended up with 5, right? We wanted to be pretty narrow. Like we eliminated animal studies, we eliminated XYZ things. So we kind of narrowed it down to just studies on human subjects that looked at XYZ. I don't want to go through our whole criteria right now, but basically narrowed it down to 5 studies. 2 of them were retrospective studies, and Oswald et al., the one we discussed tonight, is one of them, and another retrospective. And then we have 3 prospective studies. But basically, the bottom line that what we kind of found was just there's a lack of published research on this topic. There's just a few studies, some of them are pretty small. Like I mentioned, I think one of the other prospectives is super small, has like 5 patients or something. So just not a lot of great literature, and the evidence is pretty low level. And unfortunately, the papers aren't super high quality, and they're very heterogeneous in design. So a lot of them do it a little bit differently. Like one of them just did an MRI after RFA, so we don't have an MRI before. So how can we really compare? So it makes it super hard. And then there's some that look more at multifidus kind of dysfunction of the muscle, not just atrophy. Some just look at atrophy. This one looked at kind of the fat volume, right, in Oswald's paper. So there's kind of a lot of different ways that they looked at it, but we tried to kind of synthesize and kind of bring it together and kind of pool the evidence and look at, okay, what does the evidence show if we look at all 5 of these studies kind of together? The big things what we're kind of thinking of is kind of as far as like our future research in the future, if people thought about this topic or in the future, was basically just trying to focus on highly quality prospective studies and then have more of a longitudinal component to it. So like I was mentioning, having kind of multiple points where the spine's evaluated with imaging or functional assessments in the future. And then also looking at disability related outcomes to better assess the clinical significance of this relationship. So let's see if it does or doesn't cause atrophy, what does that do to the multifidus, or like regardless of what happens in the relationship, what does it cause clinically, right? Does it cause the muscles to atrophy? Does it lead to dysfunction? Does it lead to instability or worsening back pain in the future? There's a lot of studies out there that talk about like the presence of multifidus atrophy is correlated to low back pain. There's also studies that show that atrophy may not mean much, right? It might not be correlated to low back pain, but it seems like overwhelmingly it does, but there is some conflicting data. So kind of focusing on some more kind of functional things there. That's what kind of mentioned there too, is looking at the EMG. So looking at EMG, the multifidus, does it truly get denervated? One of the 5 studies looked at that, and there was evidence of denervation on EMG. The SWE is the shear wave elastography, so looking at kind of the movement of the multifidus and other things, and then other imaging modalities, just to kind of look at things in a pretty homogeneous manner, so you can kind of compare them more easily, and have those similar time periods like I've kind of mentioned multiple times. But I think that's a big thing. And then ideally, like these future studies would also have comparative groups, right? So folks that have chronic low back pain or have low back pain related to facet joints, but they didn't undergo RFA. So what is kind of the natural time course without having a procedure? What does it look like? And being able to compare the group that underwent RFA and the group that didn't, and see if there's any correlation or association there and how those comparisons look. So just some things to kind of think about. I think it's always good to think about when you're reading different papers is, oh, how would you do it? Or kind of get your mind thinking, oh, they did that. That's pretty cool. What if they looked at this? Or kind of when you're thinking about your own type stuff or things you want to look into if you're interested in research, but always trying to think about those things. I think it's helpful. And those are some of my references. That most of them, those first few slides was talking about lumbar facet arthropathy, but those are my references. Then just I'm done now, so I kind of just have to end. But if anyone has any questions, there's my email. There's my Twitter /X, whatever you want to call it now. I can't get away from calling it Twitter. So there's my Twitter handle if you guys want to message me or whatever. I think I'm the AOCPMR rep actually for KU. So if anyone wants to reach out or has questions about KU or what residency's like at KU or anything like that, obviously feel free to reach out. Or even if it's not about KU, you're just curious about PM&R in general or whatever, obviously feel free to reach out. Or if you have any questions or anything. I know what it's like to be in your guys' shoes, obviously at the AO school, and sometimes we don't get a ton of exposure to PM&R, so I think it's always helpful to chat with residents and stuff and do what you can to learn more about the field and stuff. So, but yeah, I appreciate you guys having me tonight. Let me chat about things, and I appreciate the comments too. So.